Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to the Voices of Otolaryngology. I'm broadcasting from 1650 Diagonal Avenue here in Alexandria. I am very excited to have Dr. Jeffrey Weingarten join us. Jeff, where are you joining us from?
I'm in the Detroit metropolitan area in Southeast Michigan.
Great. I should call you Dr. Weingarten. You're one of the giants in our field, and it's humbling to stand on your shoulders. There's an award there right behind you on the left-hand side. What is that award?
Jim Deneni kindly gave me the CEO award, the Above and Beyond award. For 40 years now, the Academy has done wonderful things for ENT and me. And it's acknowledgement of my little effort to pay back the Academy and the other otolaryngologists who have supported us throughout the years.
I just got chills thinking about you, Dr. Weingarten. You and I just met. We didn't know each other. And in my new role, you reached out and you wanted to explain to me CPOP, which you're going to do today. But you really said, let's educate members on what a hearing healthcare team looks like. Before we do that, Dr. Weingarten, what does your practice look like? It's an amazing setting, and I owe you a visit. I'm inviting myself over there. Jeff, what does your practice look like?
Well, we're in the Tri-County area of Southeast Michigan, in the Detroit metropolitan area. There's 11 physicians, 4 APPs, 17 audiologists, 6 offices. We do a high volume patient practice, and it's comprehensive. We're doing all aspects of otolaryngology. We have a couple subspecialists that work with us. We do ancillary development so that we're kind of a one-stop shop for ENT. We've got our audiology department, which I'm very proud of. Tremendous input from our audiologists to make it excellent. We do hearing aids, sleep, home sleep testing, allergy. And the goal is whenever a patient thinks of an otolaryngologist, there's so many things we can do. And so we've tried to put that all under one roof. That way patients know if they have anything head and neck, they can come to us. And primary care physician referrals, urgent care centers, ERs, they know that if they have to go someplace for one-stop shopping and do everything, they just send them to us. We're also very involved in teaching. And so we have Michigan State medical students. We have 4 different clinical fourth-year audiology programs that send their fourth years to us. We have our own community-based residency program that's certified. We teach primary care physicians from 3 different hospital systems. So it's a comprehensive setting. It's kind of like a university setting in a private practice office. We do it all.
The number that stood out to me, and I'll ask our audience, what number do you think made me fall off my chair? 17 audiologists. And that's the concept of the hearing healthcare team. So why don't we do a little bit back and forth? Because if I could probably give you the mic and you could go for 50 minutes on the hearing healthcare team. Let me first start with, what are these 17 audiologists evaluating? Are they busy? And you've told me you follow the guidelines and you've caught really important stuff hearing and helping the community of Detroit. Jeff.
Well, so the thing that I left out is we also have 12 CPOPs. We have 2.
All right, define CPOP because people might not understand that.
The American Academy of Otolaryngology, under Jim Deneni and a couple of others, 22 years ago, created an ENT staff training course to teach staff how to do hearing testing. That's comprehensive hearing testing and tympanometry. The course initially had several sites around the nation, and then as things evolved, our site here in Southeast Michigan retained the opportunity to continue the course, which we've done. We get about between 30 and 36 students twice a year to come to Southeast Michigan. We have a training center with our hospital system here, and we teach office staff how to do hearing testing. What that does is it frees up audiologists from doing the mundane presbycusis. I don't mean it's mundane, it's very important work, but the regularly occurring basic audiograms, and lets them work at the top of their license to rehabilitate patients.
Yeah, I'm going to keep interrupting you because I want to put myself in a lay member, somebody who might not know our acronyms or some of our international members. So you said you train staff. So I'm an otolaryngologist in private practice. Can you define staff? Who could and is able to do the CPAP? What do you mean by staff? Like, what credentials do they need?
The staff can be anybody who you trust and who has an aptitude to help patients. So you can identify somebody from the community to work as your employee for the sole purpose of doing hearing testing, or you can take a trusted member, an office manager, a medical assistant, or an ancillary staff member, a person who's part-time phones and you need more time for them, and we can train them to do hearing testing. What we found is that once you train somebody, they lose their original position. They go full-time into hearing testing, but then they're backup for some staff members. So if they're not doing hearing testing,
Exactly.
they can do
Exactly.
other jobs. The
And
nice
you've
thing about these people, this staff, is in between hearing tests, they can help patients with hearing aid difficulties, such as dome replacement. In the olden days, if you will, battery replacement. I'm smirking because there's still battery replacement. Repairs. They can also do some of the computer work that frees up the audiologist to do the things at the top of their license: tinnitus rehabilitation, hearing aid dispensing,
So
hearing aid
Jeff, hold
evaluation.
on a second. I want to go back. I'm going to keep going back because it's very, very important. So you used a keyword earlier. We could train staff to do hearing evaluations in the certificate program for otolaryngology personnel. So folks, CPOP, Certificate Program of Otolaryngology Personnel. You're looking at Jeff Weingarten, who helped found the program and continue it in Detroit. We're very grateful for that. You used the word comprehensive test. You use that, not me. What do you mean by that?
Well, the comprehensive test has the CPT code 92557. And it includes air conduction, bone conduction, discrim. It's everything defined under that CPT code as the comprehensive hearing test. And they can also do basic tympanometry.
So pull me back. I have a staff member who wants more out of their career, and I've identified them as a high potential. They're interested in really helping patients. They attend the CPOP program, which you're going to tell us about in a second. They
Certainly.
come back, they perform comprehensive audiological evaluations, and we can obtain reimbursement using CPT 92557. Is that correct, Jeff?
Correct.
But then the beauty of what you've constructed is amazing. You have 17 audiologists, 12 CPOP, Certificate Program of Otolaryngology Personnel certified. But they tell us how they work together. Your setup is really neat, how you get the patients in. Can you talk a little bit about the hearing healthcare team? And then I'll get us back to the CPOP course. Don't worry, I'm taking notes.
Good. So the hearing healthcare team is actually much more extensive than what goes on in the audiology section. And the hearing healthcare team includes our phone staff, which are trained to deal with hearing patients, hearing loss patients, and patients with hearing aid problems. It's our receptionists at check-in who are trained to deal with hearing aid problems, and we train them extensively. And then it has to do with the medical assistants who kind of screen patients for hearing loss. And then we go to the CPOP, to the audiology section, where the audiologist or the CPOP, whoever is available, will do the testing. Then it comes back to the physician to complete the cycle of the hearing healthcare team. This team concept is no different from the cardiac team or the stroke team or the pulmonary team that we've all acknowledged brings better patient care at the hospital. So we just extend that into the office, and we have the hearing healthcare team. Now, the hearing healthcare team, very importantly, is supported by training, and the training comes from the physicians, and it comes from the audiologists, and it also comes from the manufacturers and the vendors. So there's lots of places that the hearing healthcare team and some of the buying groups also. So the hearing healthcare team is comprehensive. And we learned that no one discipline can really take good care of a patient in a one-stop shop, complete healthcare team situation.
Awesome, awesome
So the
example.
patient journey, should we go through the patient journey?
Yeah, in just a sec, because I want to make a comment that's going to get Gene Brown, our president-elect, upset. I try to look for 10x opportunities. When you put 1 + 1 together and you have more than incremental gain. And what you've described is a huge 10x opportunity. Didn't happen overnight, Jeff. It's happened over time. Before we talk about the care journey, I want to ask you, well, in that, I think you're going to talk about the guideline. Well, you'll talk about it in the guidelines and how you adhere to that. I'll make sure of that. Tell me a second, who bills the 92557? The CPOP tech, the audiologist, or if you're in the office, Dr. Weingarten?
We're using it as an incident to situation. So the physician will bill the test. When the audiologist bills the test, they have their own NPI number.
Exactly.
And the
Okay.
physician doesn't bill the test. It should be noted that at the present time, the CMS does not accept billing for Ototech workload.
Yeah, understood. Take me through the care journey, and can you talk about the guideline? Because I think it's amazing. You follow our Academy guidelines and
Yeah.
you are helping patients at scale. Can you talk about that, Dr. Weingarten?
Pleasure. So our patient journey begins at check-in, and our check-in person identifies them by chief complaint if they have a hearing difficulty. But we've also, based on the clinical guidelines from the Academy, identified that everybody over a certain age should have a hearing screen. It's just part of an ENT exam. If you go to the eye doctor, they check your vision regardless of what the problem is. When you go to the ENT doctor, the otolaryngologist, a hearing screen is important. And the Academy identified that a hearing screen over the age of 50 is important. We tried to implement the over 50 screening rule, but we got inundated with patients and we couldn't handle it based on patient volume. So we implemented an over 60 rule. And the over 60 rule states that if you're a new patient over 60, you automatically get a screen. And if there's pathology identified on the screen, then a formal comprehensive hearing test is performed automatically. If you're over 60 and an established patient but haven't had a hearing test in the last 18 months, the check-in person at reception flags your chart if you get the over 60 rule, and the MAs will then bring the patient back, talk to them about getting a hearing screen, check their ears, and take them for the screen. We tried to follow the Academy's rules. We just didn't have the manpower to do it, and that's do it for everybody over 50. And I totally agree with that because we know that 25% of people under the age of 40 have some type of hearing loss. So we're doing the best we can. The very interesting thing is, in doing this, we found that patients with a chief complaint not ear-related or hearing-related, many of those patients, and I mean many of those patients who come in with sinus problems, allergy problems, hoarseness, dysphonia, many of those patients over 60 also have a hearing problem that was not identified. We also put together a little questionnaire to screen every single patient who comes in on sleep apnea and hearing and allergy difficulties. And that's just an additional screen that we do.
So there's a screen. I'm sitting in your waiting room, or I'm talking to your front desk. I get screened, and I'm 64 years old. And then the MA looks in the ears, medical assistant, and says, okay, you can get that comprehensive audio. Is that done by a CPOP, certificate program of otolaryngology personnel, or a audiologist? Is it depending on availability? Walk me through that journey.
Totally based on availability. Check-in flags them. The second screen is done by the MA, and the MA then looks in the ears and takes the patient to our in-house audiology section, which is just a short walk down the hall.
Yes, yes.
And then somebody performs the screen automatic, whether it's the Ototech, which is what we call our CPOPs.
Okay.
So anybody trained at the CPOP course is subsequently called an Ototech.
Thank you.
That either the Ototech or the audiologist, based on availability, will do the hearing screen, identify pathology, will then do a formal audiogram, the comprehensive audiogram.
The Ototech or audiologist, either one.
Correct. And then if this is a unique thing that we're doing that has gotten kind of accolades by several physicians from around the nation who've come to our office to see what we do. So at that point, a hearing loss that's aidable is identified. And we have an audiologist come in and visit with the patient for initial very brief consultation. Following that very brief consultation, which is largely education, the patient then goes to be examined by the physician for the first time. The sinus patient who has a hearing loss now gets their sinus problem taken care of. They get their hearing problem taken care of. The hearing loss patient gets their hearing loss taken care of. And if we've identified on the screen coming in, they also have sleep apnea, we talk to them about that too. So even our rhinologist is picking up hearing loss patients and supporting good general otolaryngologic care.
Can I ask you, and I'm all over the place because I'm just in love with this model, and I've told you you should look at the population of Detroit because over 40 years you've markedly improved the population there. Where do we draw the line between where a CPOP and audiologist where do they stop? And I believe in the word practicing to the top of the license, and the CPOP Ototech has their certificate program in otolaryngology personnel. They can go to a certain level. Could you help define that?
So this is where the hearing healthcare team comes in. And we acknowledge that there's different levels of competence in everybody, in physicians, in audiologists, in technicians, and in staff. And so the hearing healthcare team, the audiologist works very, very closely with the Ototech or CPOP, very closely. Just as I have a medical assistant, the audiologist uses the Ototech as their assistant. The relationship between the team, if it's basic and the technician, the Ototech feels comfortable with the test, then the test proceeds. If there's any question that the Ototech is not capable of doing the test, they stop, they explain to the patient they're going to get an audiologist to complete it, they go get an audiologist. One of the nice things about not having a paucity of audiologists is there's always somebody available. One of the other nice things is after the Ototech completes the test, if the patient needs a hearing aid, there's also an audiologist available to provide them a consultation. And we have a lot of patients who get what we call hearing aids on the fly. They will leave or show up in my exam room with a hearing aid in.
Because they're not coming back, or it's hard to bring them back, right? So they get it right there.
An interesting statistic that we identified is if a patient goes into a freestanding audiology clinic out in the real world and they get a medical clearance form to bring to a physician for medical clearance for insurance purposes, or because there's an asymmetric hearing loss and it needs medical clearance, 65% of them never go back.
Yeah. Yeah.
So to stop our office from being a sieve, okay, losing patients who need hearing aids, we did two things. One, we put a big poster in the front in the lobby that says we do hearing aids. Doesn't do anything else. It says we do hearing aids because we found a lot of patients did not know we did hearing aids. And second, we have the audiologist speak to the patient with hearing loss before they leave the office, and the audiologist will schedule the HAE or do the HAE on the fly without asking the front desk checkout people to do it. And we found that our capture rate for hearing loss patients surged. The other thing is, we also identified that hearing loss was a medical disorder. And just like any other medical disorder, people with illness don't leave our office untreated. And our staff and our physicians really bought into the fact that if you consider hearing loss a medical disorder, you got to treat them. You can't let them walk out without the knowledge of proper care. So we've captured much more patients by implementing this process. This is a process-driven approach to hearing testing acquisition and hearing aid dispensing.
I love that. And the CPOP program is crucial in helping you screen those patients and identifying those at risk of fall, accident, depression, dementia, loss of communication. I also love, and I'll say this for our members, we're a unified specialty. You said it. That rhinology patient would have hearing loss, the head and neck patient. So you're providing comprehensive otolaryngology care. So really appreciate that. You have invited me to visit you, and I think one Monday I'll come there and observe it because to me, it's unfathomable how your patient flow must work. It must just everybody's bumping into each other, and then can you throw this seromonectomy in? I mean, you just can't do all that. So talk to me about how the patient flow looks like, and if you have a calm office.
Most of the time we have a calm office, but I can't guarantee you that it's that way all the time. One of the things we found is that if a patient brought back and the medical assistant examines the ears before taking them for a hearing test, and there's wax in the ears, which is not uncommon, especially in our screening group of over 60, then they can't send them for the hearing test. So what I've done to keep my schedule flowing and what our physicians have worked out is that we will have the medical assistant come out, take and grab us as soon as we come out of a room. They tell us, go in and clean that wax so we can get a hearing test.
But it takes
And
like 40 minutes to clean that ear. No, not for you, maybe 10 minutes, 10 minutes, right? You can pop in and do that, Jeff?
it takes a matter of seconds, frankly. And so we
Yeah.
go in, we clean the ears. I walk in, I introduce myself. Hi, I'm Dr. Weingart. I'm going to clean your ears. We're going to get a quick screening test, and then I'm going to come chat with you. There's no patients that disagree with that. And then when you clean their ears, their hearing's better, and you reassure them that it's important to get the test anyway. I'm in and out in under 60 seconds.
You know what I absolutely love about this is the team-based care. I have keratoconus in my left eye. Fine, it is what it is. And I've had it since I think college. And I'd go to the Massachusetts Eye and Ear. I trained in Boston, Jeff. And there, the ophthalmologist had a whole care team. And you now have done this in your private practice setting. To me, it's amazing, Jeff.
Yep, thanks. You mentioned that your training program kind of gave you the initiative to take and excel. And I'd like to acknowledge my training program, the University of Iowa. I spent 3 months with audiology,
Huh.
and I learned that they have a similar the audiologists have a similar passion to us. And I learned that interaction with the audiologist is very important. I learned that the way they educate patients and their contributions is very important, and it complements what we do. And what we do when we come to hearing loss is we can observe hearing loss, we can medicate hearing loss, we can operate on hearing loss. But what wasn't emphasized in a lot of training programs that we emphasize in our ENT training program is you can also rehabilitate hearing loss. And that's where the hearing healthcare team comes in, because you need to interact with people who can rehabilitate with hearing aids. And I don't even call them hearing aids to my patients. I call them listening empowerment devices, which probably is going to freak out any industry people who watch this. But patients have a bit of an obstruction with hearing aids, a bit of resistance or stigma. But when they put the hearing aids on, the benefit that they get, I mean, we all acknowledge. Okay? So from the University of Iowa, their insistence that we take and get educated on what our complementary discipline does. And I got to thank Brian McCabe and Lee Harker and Bruce Gantz. I mean, they really stress the right things, as do a lot of the residency programs. But get some audiology experience in the residency programs and learn how to take and form that comprehensive healthcare team.
Thank you for calling out the giants who you stand on, and they must be so proud of what you built. Jeff, I remember my oral board exam. I don't know if we're allowed to talk about who gave me mine, but one of the most seniorest members of our field. And I didn't do so great on the hearing aid question. And this person chided me, implored me, and then mentored me to make sure I understood. I think it's a blessing you had 3 months of training in your residency. Jeff, can I ask you a question? And we didn't discuss this. If you don't feel comfortable, you don't have to answer it, even though I'm putting you on the spot. Can you talk about volume? How many patients you see in a session? What do the audiologists see? Or if you want to talk about it over a year, I don't know, but however you want to do it, if you want to do it per audiologist, per CPOP, per otolaryngologist, I'm just running my mouth here so you can think about how you want to talk about volume. And Jeff, the beautiful thing is if you don't want to, we'll splice this question out. No one will even know I asked you. Just give a
Fine.
ballpark of, because people are going to say, Jeff, that's a lot. That's a lot. But you've made it part of your care. Can you talk maybe some sort of volume numbers?
Sure. So Our physicians, our 11 physicians, will see on an average day between 35 and 55, depending on the physician
Thank
and
you. Yep.
depending on the emphasis of the practice.
Well said.
The number of hearing tests we do, our team is always busy because we're not just testing hearing loss
Yeah.
patients. We're testing the patients that fit the AAO's criteria. I'd like to test more. We just don't have enough space. One of the things in developing our office that I very much underestimated in the beginning was the number of booths that you should have
Yeah,
and the
talk
cost.
about that. Yeah, talk about that, and we'll get back to volume. That's really important, Jeff. Please.
Okay. So I very much underestimated the number of booths. And I've been asked actually to go out and visit a couple of private practices and say, what can I, and they brought me out to say, what can I do to improve my audiology section and my hearing aid volume, my hearing aid dispensing volume. And what I found the rate limiting step frequently, obviously, is staff, but we can overcome the staff by getting the ototechs or CPOPs to help. But it's the number of booths that you have. And an extra room with an extra booth and an extra audiometer, okay, pays for itself when you take care of 15 patients' hearing problem with hearing aids. And the return on investment is of establishing a room with a booth and an audiometer. The return on investment is 4 weeks. And then you have that in perpetuity. Audiometers go bad in 15 years, booths go bad in 15 decades. So don't hesitate to take and put additional booths in.
Hold on a sec. That's very important. So 15 net new patients a day gives you a break even of 1 month on your capital improvement, more or less.
15 patients dispensing who get dispensed binaural hearing aids, traditional, not third party, will pay for your booth and your audiometer.
Got it.
So, but also the patient care involved. Once again, if you're not doing testing on those as recommended by American Academy of Otolaryngology in the guidelines, if you're not testing them, you're letting disease, hearing aid is hearing loss is a medical disorder, you're letting a medical disorder go out the door without being evaluated. And what's the cost of that to the community? So we are putting more booths in our offices than perhaps we need, thinking about quality care and expected growth.
Yeah, go back to the volume because I interrupted you. What is the rough volume that a ototech, I'm using your word, an ototech CPOP certified person, what do they see in a given day? 4, 5, or 10, 15?
No, well, so it depends on the volume of the practice, but our audiologists can do a good hearing test in about 15 minutes. I should rephrase that in case our audiologists see this. They always do an excellent hearing test in about 15 minutes.
Yes.
Our ototechs do it in about 20 minutes, 22 minutes. So instead of 4 an hour, you're getting about 3 an hour. But in that hour that the ototech is doing a hearing test, one of those patients that they've identified with substantial hearing loss can be sent to the audiologist for a hearing aid on the fly, and they show up in my exam room, usually around the time of the appointment, but sometimes 15 or 20 minutes later, with hearing aids in their ear. And then it's very important that we acknowledge that the physician's job is to help the patient feel comfortable and understand the benefit of hearing improvement over time. So it's not our job to sell a hearing aid. It's the audiologist's job to educate and dispense the hearing aid. I believe it's our job, and it's worked out superbly in our office, and let the audiologist dispense the hearing aid and educate the patient on the benefits of hearing aids and their recommendation, and give the patient the confidence that they're making a proper investment in the hearing device. And it's good for the patient because you're not going to acknowledge it's important for them to get the hearing aid if it wasn't appropriate. And they need the reassurance from you as the physician, from us as the physician, that that's the right decision because it's a significant investment. But the value of getting improved hearing to the family and to businesses, there's a lot of individuals still in business who are having difficulty communicate. It's not just a social benefit, it's a professional benefit. That reinforcement from the otolaryngologist for the audiologist recommendation is a huge benefit to patient care.
Yeah.
And that's something in the beginning I very much underestimated. And this is where the hearing healthcare team approach came in.
So I was
And
going to ask you about that. You segued perfectly. While you're talking about it, can you explain to those in practice, those starting practices, how do you build it, Jeff? Where do you start? It's very overwhelming for me hearing you to think, how do I get to 17 audiologists and 12 oto techs? What was the hardest part? Was it day one? Was it in the middle? You said it. Can you go back? Because you were about to say it. Working with your audiologist educated you. Talk to us about how we build it, Jeff.
so there's two questions here. Number one is how do you go from two physicians, which I started with, to and seven staff to 11 and one office to 11 physicians and 41 providers because we include our APPs and six offices. And it's not overnight. And what you do is you slowly develop with support of each other. So when my partners started to come in, and I'm very grateful because they've done two things. One, they've given me information and encouragement. And two, they supported some of my harebrained ideas that allowed us to expand our ancillaries and do some of the things that have turned us into the one-stop shop, high level quality of care. And we
So go
support
on that. Go on that. How did you build the audiology CPOP beautiful hearing healthcare team? What was the hardest part, Jeff? Looking back at 40 years of this, 22 years with CPOP, what was your biggest challenge?
the time. It's
Huh.
the time. So surrounding yourself by bright people in our discipline is not difficult, but you have to invest the time. And reinventing the wheel over and over and over again to take and get a true round gear, it's input from the physicians, it's input from the staff, it's input from the audiologist to make everything smooth. My MAs taught me how to make the flow at the pre-physician visit work. My audiologist taught me how to make the back room work in the audiology section. And my physicians told me what they would tolerate for patient flow. And then my administrative team, which started just with an office manager, and now we have 8, going on 10, I believe, they really did the continuous monitoring. We have monthly meetings with our audiologists. Dinner is brought in. They give me messages that they wouldn't otherwise tell people, and I give them messages that in the office I couldn't give them. And we work out problems, we work out flow, we work out bonus structure, and we do it as a team. And I'm very proud the way this developed because it really respected all aspects of the practice. It respects the difficulty the front desk people have in getting questions to hard of hearing patients. It respects the flow of the medical assistants. It respects the flow and the economic structure of the audiologists and the physicians. Well, they demand it. So we make it work by listening to everybody, and then we write it down, and we have a process, and our process for hearing aid acquisition is written down, and our process for hearing aid dispensing is written down. And then new people coming in, they don't have to learn the process, they can look at the process.
Yep. I love listening to you. It's not soporific, it's invigorating. So I'm letting these go because I think our members are going to love it. And I'm also watching the time. I have 4 topics I want to address with you, but go back to this one. So I'm an otolaryngologist in a small practice, and I have an audiologist, and I'd like to go down the CPOP pathway. Should I be intimidated? Can I start with an N of 1? Can we do it and start building it? Can you give me that confidence? Do you see that? And then why don't you build on that and tell me, who are you seeing in the CPOP course? You said there's about 3 dozen. Are they from mega practices? They're from solo practices? Can you answer both of those, Jeff?
Yes, everybody should have a CPOP. At the Oto Forum last year, there were 260 physicians present. 28% of them had a CPOP in their office.
Very important. Hold on. Let's extrapolate that. So you think in our specialty, maybe about 1 out of 5 practices, if I mean that was a representative sample, but it's out there, right, Jeff? They're using them.
We've trained over 800 CPOPs in the 22 going on 23 years. They're just invaluable. Our practice could not run without a CPOP. So should small groups, mid-sized groups, and large groups be using CPOP? No question about it. The benefit
and they can just do it, right, Jeff? They can work with they don't need to be intimidated.
Correct. And the next course is we do a course in May, first weekend in May, and first or second weekend in November every year. First or second weekend, depending on when my wife's birthday falls. We should talk about the course, and then we'll go into.
All right, so keep it brief. Talk about the course because I want to do more things.
So the course has 3 parts. Part 1 is a pre-course. Part 2 is a post-course. Part 2 is a course, a weekend course, and Part 3 is the post-course work. Pre-course work, we send out a pre-test and a syllabus with a reading recommendation. We acknowledge that most of the people coming are not going to be college graduates. They're going to be office staff. So it's an education appropriate textbook. The goal is to have the pre-course work done by the attendee, working with the audiologist, developing a relationship between them. And they spend a couple of weeks intermittently doing some testing in the booth, learning about it. So the office identifies them as having the aptitude, and the attendee is identified as actually having an interest. Then they come to suburban Detroit, which is a wonderful place, Novi, Michigan. It's set right in the middle of what used to be a forest preserve. And we have a weekend course at an educational center that's associated with Ascension Hospital. Now it's Henry Ford Ascension Hospital, and it's an actual educational center. It's a formal location of learning. 50% of the weekend is didactic learning from lectures from otolaryngologists, and 50% is actually in booth time. Sunday afternoon, they fly back home, where they have to work with the audiologist and document 60 full audiograms to complete their testing. Because to get a level of proficiency that's respected, we found that about 60 full audiograms is what's needed. That also gives them time to bond and develop a relationship with the audiologist, and also to give the audiologist confidence that they have a certain skill level, and that develops the team approach. So the course is educationally appropriate. It's a fun course. We reinforce the benefit to the attendee that they will have on the community. The biggest resistance or impetus that we found is that the audiologist who's not had a CPOP before will take and have resistance, thinking they're going to take over their department. Contrary to that, once they get the CPOP, they can't be thankful enough for the CPOP. So for those audiologists who take and balk, we encourage the physician to have the audiologist call our audiologist. You'll find out the benefit of having an audiology assistant, if you will, a colleague. Like I have a medical assistant, they have a colleague to help them with some of the basic things that lets them work at the top of their license. The value that they have to the audiologist is then recognized by the audiologist being immense. Immense is an understatement.
Jeff, go back, and you can use any sample size, 1 year, 5 years, the history of the program. And I just want a general demographic of a CPOP attendee. You said it, they're not college graduates, understood. Are they from small and mid-sized practices, generally male, female, mid-career, early career, late career? Just build out kind of the attending, or I bet you it might be everything, all of the above.
It is everything. It's about 2/3 female, 1/3 male.
Thank you.
I think we've got 45 states that have been represented. We've had individuals from Canada come in. We've had the American Virgin Islands sent representatives. I believe we had somebody from Cuba once. So it's an international.
And mid early late career, Jeff, where are they in their career life cycle?
Early to mid. We've had office managers, medical assistants. We'd have individuals who have what I call odd techs, AUD tech, who have been doing clerical work for the audiologist. And this is actually a stepping stone pathway that can be used in the office to take and give promotions to valued staff.
Yeah.
And so if you identify a front desk staff or a phone staff or a medical assistant who wants to ascend in the patient care department, they can become odd techs or odo techs, the difference being odd tech does clerical work and some hearing aid repair and hearing aid assistance, where the odo tech does that plus can do hearing testing.
So that's important. Is the odd tech a word you coined? Is it an industry word? Is it on the audiology side? And can you explain the difference? Because I hear these words interchangeably, and I just want our members to be very clear. I got odo tech, but go ahead and build odd tech out of it.
Yeah, it's actually something Jim Deneni and I kind of coined. The odd tech does clerical work but not testing. The odo tech is a CPOP who has been trained, who can do testing and clerical work and any other assignment that the audiologist gives them. So we have them doing pretty much everything shy of programming, hearing aid evaluation, and dispensing. And it's based on the commitment that the staff member makes and their aptitude. If they're not qualified, they work to the limits of their ability. They don't go beyond that. And that's determined by the audiologist.
Thank you. One point, a couple more points, and we'll wrap it up. We've been focused internally on your practice. What is the external environment in Detroit and where you practice with the other audiologists, with the referring doctors? Talk to me about the perception out there. They probably have gratitude that you have 19 folks that are doing audiograms. Talk to me a little bit about external.
In Michigan, we really have a wonderful group of otolaryngologists and a strong state society with a very strong state audiology society as well. So Michigan Oto Society, which is MOS, and the MAC, the Michigan Audiology Coalition, it's a very good relationship that we have within one another. When the audiologists needed licensure several years ago, they came to Michigan Oto Society and we worked together and we got licensure for audiologists. Same thing happened with the speech and language, the SLPs. They came to our state society and we worked together to put a wonderful licensure law. We were one of the very few states that didn't have a licensure law for either one. I was fortunate to have been asked to be one of the representatives, otolaryngologists, to take and put that together, which subsequently put me on the state board of SLP, which just goes back to the initial premise that we talked about a few minutes ago. What does it take to do a good job? Time.
Yeah, I appreciate that. Can I run through a few more things, and I promise you we'll get you back to your office because I've taken a lot of your time today. You are very generous. You've invited me to visit, but folks do visit your practice. If members have an interest, could they email you? How do they reach out to you to learn how you have built this over 40 years, how you have a model, how you use 92557 as an incident to how you use the Academy guidelines, how you pop in, do that ceremonectomy and do holistic care? It's exciting. I know you welcome guests. Can I offer that up to our listeners?
Sure. Thanks. It's a peer visitation program that we kind of informally put together. I'm rather proud of it because it's made some very nice contributions to quite a few otolaryngologists around the nation. It's one of my favorite journal articles in the past was the How I Do It article. It was short, sweet, cookbook, and just made sense. And to see something working gets a lot of the obstacles out of the way. To reinvent the wheel takes time and effort that a lot of us don't have. We have family commitments, we have staff commitments, we have meeting commitments, hospital commitments. We've just taken a decade or more and put something really smooth together. So patterning off of what used to be done with balloons, where you'd go to a nation's expert and see how they did it, we came up with this peer visitation program. We don't really get anything for it. We don't ask anything for it. It's a way of giving back to AAO and the otolaryngologist community that has done so much for us. So yeah, they can contact me through the academy. We encourage consideration for a administrator, a lead audiologist, and a physician to come in on Sunday. On Monday, you spend the morning with us. The physician works with me. The audiologist works with our audiology team. The administrator works with my administrator. In the afternoon, we have a long lunch. You get on a plane, you go back, you miss one day work. And it's really teaches you how to implement something without taking 10 years to develop it. That's if you want to develop that aspect of things. Now, we also do home sleep studies, and that's a little adjunct. And we also have a very strong allergy program that Dr. Merle, my colleague, is in charge of. So it's that comprehensive nature that I think really benefits otolaryngology. And I've just been very fortunate to have some very strong physicians who have developed it with me, and I appreciate that. So contact me through the academy. That would be wonderful. We look forward to that. You can also talk to perhaps some of your hearing aid vendors to see if they're interested in sponsoring something like that.
Yeah, thank you. Love that your peer program epitomizes, encapsulates, demonstrates a concept of the team. It's not just the otolaryngologist, and that's just a statement I'm making. I love how you bring the audiologist, the administrator, and the otolaryngologist. Just a few more questions, I promise. I know you probably have patience in a bit. The Charleston ENT group has Stuffy the mascot. Have you seen Stuffy?
Yeah, I'm very proud of Gene. He's brilliant, absolutely brilliant.
Well, Jeff, 40 years, buddy, 40 years, Dr. Weingarten. What's the mascot for you all? You have hundreds of employees, 6 offices, 41 providers. What's your mascot, Jeff?
You know, having watched Gene's webcast, we are about to develop a mascot.
No way.
Next webcast that we do, I will make sure that I'm dressed in full regalia of whatever our mascot ends up being.
Well, I want to thank you, and I started with that award to your left there, and I'll end with it. It's just a small token that Dr. Denany bestowed upon you for really, I think, transforming the way we approach comprehensive audiological screenings with CPOP, et cetera. And I'm new in my role, and I've already learned about your contributions, and I thank you. I'll give you the final word, Jeff, but what I will say on behalf of our members in our academy, thank you. And that award is a simple recognition of your 40 years of work. But Jeff, please, any final thoughts for our members out there, the hearing healthcare team? I'll give you the final word, sir.
No, well, I guess I have to thank AAO because of the opportunities that they've opened up for me since I joined as a resident quite a while ago. The work that's done by yourself, your predecessors, Gene, and all the previous presidents, and the hundreds of physicians and the staff that put the time and effort in to make our profession excel as it does. You guys have my gratitude. I don't think I could do what I'm doing today without the benefits that the AAO has bestowed on me. So the respect and the admiration and the compliments go both ways. And I thank you for offering me the opportunity to visit today.
Awesome. Thank you, Jeff.
Bye.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.